Good morning, ladies and gentlemen. In today's lecture, I am going to discuss two topics. The first, as flashed in front of you, is the DNA repair disorders with cutaneous features. And the second will be premature aging syndromes. So let's go along with the first topic. The first disease which we are going to discuss among the headings of DNA repair disorders with cutaneous features is a very common condition that is called as Xeroderma pigmentosum. Xeroderma pigmentosum is a rare autosomal recessive disorder of DNA repair. It is characterized by progressive pigmentary changes at the exposed sites and increased risk of ultraviolet radiation-induced skin and mucous membrane cancers. Severe photosensitivity is seen in 50% and neurodegeneration in approximately 30% of affected individuals. So as the name signifies, pigmentosum, this is a disorder of pigmentation, mainly on the exposed surfaces with increased risks of cutaneous and mucocutaneous cancers. And there is severe photosensitivity, and another systemic feature of the syndrome is neurodegeneration. The disease is divided into 8 complementation groups labeled as Xeroderma pigmentosa A to Xeroderma pigmentosa G and Xeroderma pigmentosa V, which is a Xeroderma pigmentosa variant. There is wide variability in clinical features, both between and within Xeroderma pigmentosa complementation groups. Xeroderma pigmentosa is found worldwide in all races with an equal sex incidence. It occurs with a frequency of 1 in 250,000 in Europe and USA. Fibroblasts from most patients with typical Xeroderma pigmentosa lack the normal capacity to repair ultraviolet radiation damage to DNA. This is the main reason of inclusion of this disease in the heading, that is the DNA repair disorders. So the fibroblasts from such patients are unable to get repaired following a UV radiation-induced damage. Approximately 80% of patients with Xeroderma pigmentosa show a defect in initiation of DNA excision repair of ultraviolet products. The unscheduled DNA synthesis assay following UV radiation of cells in culture is the standard laboratory method of diagnosis of Xeroderma pigmentosa. Although clinically the syndrome is very typical, but if you go for an laboratory investigation, that it is the unscheduled DNA synthesis assay. Nucleotide excision repair. Nucleotide excision repair, or NER, is made up of 2 pathways. The global genome nucleotide excision repair, in which damage to DNA not undergoing transcription is repaired, and transcription coupled nucleotide excision repair, in which damage in transcribed region of DNA is rapidly repaired. So one of the region is that region which is not going transcription, and other is the region which is undergoing transcription. So both regions are usually repaired in a normal individual. This process whereby damaged DNA is removed and replaced by new DNA using intact strands as templates involves the products of some 30 genes. Mutation in any of the 7 genes encoding for these proteins, from Xeroderma pigmentosa A to G, results in abnormal nucleotide exchange repair. excision repair, and the different xeroderma pigmentosum complementation groups are formed. About 20% of patients with xeroderma pigmentosa, the so-called as xeroderma pigmentosa variant, HPV, have problems replicating DNA containing UVR-induced damage. They have defects in POLH or XPV gene, which encodes for DNA polymerization N, one of the specialized enzymes that is required for replication beyond the damaged sites. So it is summarized that different complement groups of xeroderma pigmentosa have different mutations that results in defect in excision repair, nucleotide excision repair in a certain region of the DNA. Clinical features. Various subtypes of xeroderma pigmentosa show clinical and epidemiological differences. The clinical manifestations, severity, age of onset are dependent on cumulative ultraviolet radiation exposure, the complementation group, and precise nature of the pathogenic mutation. So there are some general features which I have mentioned in the start of the topic, but there are some differences in clinical manifestations, severity, and age of onset. And these differences are determined by the specific mutations in specific complementation groups of xeroderma pigmentosa. Skin changes. The skin is normal at birth, and the first symptoms are noticed between 6 months and 3rd year in over 75% of the cases. Most cases begin in early childhood and have reached the tumor stage before the age of 20 years. The later changes are the result of amount of sun exposure and degree of ultraviolet radiation protection. So if the disease is not recognized early and patient is not advised ultraviolet protection, then this stage of skin cancer comes very quick. Delay in diagnosis and poor sun protection will exacerbate the cutaneous feature, result in significant pigmentary changes and tumor stages. Acute or severe sunburn on minimal sun exposure taking weeks to resolve is the cardinal presentation. This is the initial presentation of most of the patients. That is acute and severe sunburn on minimal ultraviolet radiation exposure. Patients in complementation groups, xeroderma pigmentosa A, B, D, F, and G, suffer from severe sunburn reactions, whereas those in group C, E, and V have normal sunburn reaction for the skin type. So 5 of the complement group have severe sunburn reaction, while 3 of them have minimum or the usual sunburn reactions. The pigmentation is mainly the lentigens, and they are fixed and progress over time to become more dense and irregular. As they increase progressively in number, telangiectasias and small angiomas appear interspersed among them. So initially it is the lentigens or pigmentation alteration. Later on, these lentigens, they progress, increase in size, become irregular. Telangiectasias develop and small angiomas also develop. Then small, round, or irregular white atrophic spots are soon added to the picture. So the initial picture is that of lentigens, telangiectasias, angiomas, and small white atrophic spots. Then comes the tumor stage. Xeroderma pigmentosa patients have 10,000-fold increased risk of non-melanoma skin cancers, and 2,000-fold increased risk of melanomas under 20 years age. So this is a significant risk. The median age of diagnosis of non-melanoma skin cancer is 9 years, and median age of diagnosis of first melanoma is 22 years. Keratoacanthoma and actinic keratosis are frequent, and they may undergo malignant changes. Xeroderma pigmentosa patients also have approximately 50-fold increase in medulloblastoma, glioblastoma, spinal cord astrocytomas, and schwannomas. These precise relationship to DNA damage is not known. Eye changes. The eyes are affected in 80% of the cases. Photophobia and conjunctivitis are the common early symptoms. Later on, ectropion and destruction of lower lids, vascular pterygium, corneal opacities, and epitheliomas of lid, conjunctiva, and cornea may develop. Neurodegeneration. The neurological abnormalities occur in approximately 20% of xeroderma pigmentosa patients, and these abnormalities include mental retardation, areflexia, or hyporeflexia, spasticity, ataxia, sensorineural deafness, dysphasia, and abnormal EEG findings. Patients with neurological abnormalities usually have group A and D disease. So the neurological symptoms are common in group A and group D. Psychological effects. Many patients with xeroderma pigmentosa results in social isolation, low mood, depression, and anxiety. Compliance with extreme sun protection is also an issue. This is a severely affected case of xeroderma pigmentosa. And in this patient, you can see multiple tumors, which include the actinic keratosis and some non-melanoma skin cancers as well. Disease course and prognosis. There is, of course, no cure for xeroderma pigmentosa. The overall median age of death is reported as 32 years, with skin cancers and neurodegeneration as the main cause of death. For those without neurological disease and having a rigorous ultraviolet protection, the prognosis is not that bad. The neurological abnormalities are progressive, and median age of these patients for death is 29 years compared to 37 years in patients without neurological degeneration. Investigations. Most cases, this is a straightforward clinical diagnosis based on extreme and exaggerated sunburn reaction and appearance of lentigens on face and other exposed sites from the early age. The diagnosis can be confirmed definitely by cellular tests for detecting the DNA repair defect. The most commonly used is a measure of unscheduled DNA synthesis in cultured skin fibroblasts. Subsequently, analysis of DNA by extraction from a blood can identify the defective gene, confirming the causative mutation. Treatment. The patient must be protected from sunlight by every possible means. They must not go outdoors during day hours, except in early morning or the evening, and even then they should wear 2 layers of clothing and a broad brimmed hat. The uncovered skin surface must be protected by total sunblock cream. Sunglasses with side shields should be worn. Early and adequate excision or treatment of the tumors is essential. Topical 5-fluorouracil or imiquimod may be useful for early or pre-malignant lesions. Chemical peeling and dermabrasion is also helpful. Oral retinoids reduce the incidence of skin cancers. Eye treated with artificial tears, soft contact lenses, and even corneal transplant. A recent clinical trial using microbial enzyme T4 endonuclease V or 5 applied regular as a topical liposomal product. This enzyme is able to bypass the defect in Xeroderma pigmentosa cells, and over a period of 1 year, it significantly reduced the onset of both new BCC and actinic keratosis. So this is something new. The microbial enzyme T4 endonuclease 5 and has some prospects in the future treatment of Xeroderma pigmentosa. The second syndrome I'm going to discuss today is the Cockayne syndrome. The Cockayne syndrome is a rare autosomal recessive disorder of DNA repair that is characterized by short stature, photosensitivity, distinctive facial appearance, ocular defects, premature aging, and progressive neurological dysfunctions associated with extensive demyelination. So the syndrome is similar in many respects to Xeroderma pigmentosa, but different as well. The patients of Cockayne syndrome and Xeroderma pigmentosum both have photosensitivity. Both are short stature. There are ocular defects. Premature aging is not seen in Xeroderma pigmentosa, but progressive neurological dysfunction is seen in both syndromes. There is no distinctive facial appearance in Xeroderma pigmentosum, but it is seen in Cockayne syndrome. It's an autosomal recessive and seen in both sexes, but is rare. Cockayne syndrome is divided into 3 subclinical types, type 1, 2, and 3, based on severity of the disease. Cockayne syndrome results from mutation in one of the 2 genes, the ERCC8, also called as Cockayne syndrome A gene, or ERCC6, which is labeled as Cockayne syndrome B gene. The product of these genes are involved in nucleotide excision repair defects. The associated failure of cells to restore normal level of RNA synthesis after ultraviolet-induced damage has provided a mean for carrying out complementation tests on Cockayne syndrome cells, and 2 complementation groups have been identified, Cockayne syndrome A and Cockayne syndrome B. The clinical features. The child usually appears normal for the first year, when facial erythema in butterfly distribution develop after exposure to sunlight. So the disease starts with severe facial erythema in butterfly distribution and not as pigmentary changes, as we see in Xeroderma pigmentosa. The sensitivity to light is eventually lost, but not before the mottled pigmentation and atrophic scars have given the patient a premature senile appearance. So not like Xeroderma pigmentosa, the sensitivity of light gradually reduces as the patient ages, but the resultant skin, that is the exposed skin, is characterized by some mottled pigmentation and atrophic scars, which we see in old age. So the patient gives a senile look. There is characteristic bird-like faces that include prognathism and ophthalmia, prominent and thin nose, large ears, and loss of subcutaneous fat. There are disproportionately large hand and feet, cachexia, and dental caries. So in old literature, it was also simulated with Mickey Mouse appearance. The skin is dry and thin, and hair is often sparse and is sometimes prematurely gray. So all the features of premature aging are there. This is a patient of Cockayne syndrome. In contrast to Xeroderma pigmentosa, Cockayne syndrome has no increased tendency of skin cancers. The neurological features comprises of extensive demyelination of peripheral and central nervous system, progressive cognitive decline, chorioathetosis, hydrocephalus, and spasticity. The ophthalmic problems include retinal degeneration, cataract, and optic atrophy leading to loss of vision. There is progressive sensorineural deafness, skeletal abnormalities, and flexural deformities. Disease course and prognosis. Patients of Cockayne syndrome type 1 commonly die before the end of second decade as a result of progressive neurological degeneration. Patients of type 2 have worse prognosis, where patients of type 3 often survive into adulthood. Survival beyond second decade is unusual, and mean age at death is reported as 12.5 years. Investigation. Tests for Cockayne syndrome therefore involves ultraviolet irradiation of cells followed by measurement of RNA synthesis 24 hours later. In normal cells, RNA synthesis will have recovered in untreated levels, whereas Cockayne syndrome cells, it remains depressed and low. Analysis of DNA extraction from blood can identify the defective gene and causative mutation in patient. This can enable genetic counseling and prenatal testing if requested. Management is purely supportive and requires multidisciplinary approach from clinical genetics, ophthalmology, neurology, dermatology, ENT, and physiotherapy. Patients should avoid ultraviolet radiation exposure because of their increased photosensitivity. Therefore, vitamin D deficiency is common and supplementation should be given lifelong. There is no increased risk of skin cancers, however. Patients should be given appropriate genetic counseling. Prenatal diagnosis is possible by amniocentesis from chronic villus sampling. The third syndrome I'm going to discuss in DNA repair defect is Trichothiodystrophy. It's again an autosomal recessive disorder of DNA repair. It is multi-system disorder that is characterized by short brittle hairs, photosensitivity, ichthysis, developmental delay, and short stature. Trichothiodystrophy is divided into photosensitive and more non-photosensitive subtypes. The incidence of trichothiodystrophy is estimated in 1 per million live births, affecting male and females equally. Photosensitive trichothiodystrophy result from mutation in DNA repair gene ERCC2, which is Xeroderma pigmentosa D gene, or ERCC3 or Xeroderma pigmentosa B gene. Trichothiodystrophy patients have not been reported to have an increased risk of cancer, while the clinical features in Xeroderma pigmentosa are related to abnormal repair of ultraviolet radiation-induced DNA damage in skin. But in TTD, trichothiodystrophy is primarily a disorder of development resulting in transcription abnormalities. Clinical features. Trichothiodystrophy is characterized by short, brittle, sulfur-deficient hairs with patterns of alternating light and dark bands under the polarized light microscopy. So the main effect is on the hairs. Then 50% have photosensitivity with severe and exaggerated sunburn reactions. However, there is no increased risk of skin cancer. Other cutaneous features include ichthysis, clodion membrane at birth, nail may be brittle and demonstrate onychodystrophy. Pregnancy complications include intrauterine growth retardation, preeclampsia and eclampsia, low birth weight, and premature births. There is intellectual impairment, short stature, facial dysmorphism with microcephaly and large ears and microgentia. So you can see the typical sulfur deficient hairs showing alternating light and dark bands. Ichthyosis is seen in this image, and here the typical features with microganthia is seen. Patient gradually developed joint abnormalities with contractures and dislocations. Many patients are anemic and neutropenic and show hematological features of beta thalassemia trait. There is severe and recurrent infection, especially respiratory infection, occur in first year of life. Spectrum of clinical features varies from mild disease with only hair involvement to severe disease with profound developmental defects and recurrent infections. The differential diagnosis includes Cockayne syndrome, Xeroderma pigmentosa, and congenital alopecia, especially Menkes disease and Netherton syndrome. Disease course and prognosis. There is no cure for Trichothiodystrophy. There is significant morbidity and mortality in neonatal and childhood years. Overall median age of death is reported as 3 years with pneumonia and other infections. So Trichothiodystrophy is fatal, much more fatal as compared to Cockayne syndrome and Xeroderma pigmentosa, with age of death around 3 years, mainly because of infection. Investigation. The diagnosis can be confirmed definitely by cellular test of DNA repair. A reduced level of UDS confirms the diagnosis of trichothiodystrophy. Management requires a multidisciplinary approach. Patients and their families should be given appropriate genetic counseling and prenatal diagnosis offered if required. Any infection should be aggressively treated as mortality from infection is significantly high, that is 20-fold higher. Sun protection is advised in those patients who have photosensitivity. The fourth syndrome we are going to discuss is ataxia telangiectasia, also known as Lewis-Barr syndrome. This is again an autosomal recessive disorder of DNA repair, a multisystem disorder characterized by ataxia and mucocutaneous telangiectasias. The telangiectasias initially appear in conjunctiva and is more prominent in facial areas. So the telangiectasias are the first manifestations that appear before ataxia sets in. Additional cutaneous features include premature hair graying, caffolae spots, pigmentary changes that includes poikiloderma. There is progressive cerebellar degeneration, which is the first clinical manifestation that starts about 1 year of age. Cancers may also develop. Immunodeficiency with increased susceptibility to infections, hypogonadism, sensitivity to ionizing radiations, insulin resistance, and predisposition of cancer are the cardinal features of ataxia telangiectasia. It is a chromosome instability disorder with inactivating mutations in ATM gene. Management is symptomatic and involves a multidisciplinary approach, as the cells of ataxia telangiectasia patients are sensitive to ionizing radiations. X-rays and radiotherapy should be used with extreme caution. Prognosis is poor because of severe respiratory infection, progressive neurodegeneration, and increased risk of cancers. So the fifth syndrome I'm going to discuss is the Fanconi anemia. It is again an autosomal recessive disorder and a DNA repair defect. 2/3 of the patients are born with congenital malformations of kidney, heart, skeleton, which is absent or abnormal thumb and radii. Other features include typical facial appearance with a small head, eyes and mouth, hearing loss, hypogonadism, and reduced fertility. The cutaneous abnormalities include reticulate or patchy hyper and hypopigmentation, again the poikilodermatous appearance, and caffolae spots. Bone marrow failure, which is the main feature present in first decade of life. Subsequently, patient develop tumors such as lymphomas, esophageal carcinomas, squamous cell carcinoma of head and neck, liver and brain, tumors, and acute myeloid leukemias. Diagnosis is based on evaluation of chromosomal breakage induced by alkylating agents such as mitomycin C. Bone marrow failure and cancer result in poor prognosis, and life expectancy of such patients is reduced to average of 20 years. Management involves supportive care with transfusions as necessary. Hematopoietic stem cell transplantation is curative for hematological features, but this increases the risks of solid tumor which develop post stem cell transplantation by the chemotherapy that is given after that. Muir-Torre syndrome. The Muir-Torre syndrome is autosomal dominant disorder of DNA repair. So this is the first disorder of autosomal dominant inheritance, which we have discussed so far, and occur as a result of mutation in one of the DNA mismatch repair gene, MSH2 or MLH1, or more recently MSH6. This is characterized by sebaceous gland neoplasm, sebaceoma or sebaceous adenoma, and or keratoacanthoma associated with one or more gastrointestinal or genitourinary malignancy. These malignancies often behave less aggressively and are of low grade. Management involves genetic counseling, regular skin reviews, and appropriate cancer screening. So this ends this chapter, and now I am going to give another lecture on the syndromes with premature aging. This is a separate chapter in Rook. So among the syndromes of premature aging, the first syndrome which we are going to discuss is the Werner syndrome. Werner syndrome is characterized by premature aging, short stature, premature atherosclerosis, diabetes, and predisposition of malignancy. Among the premature syndrome, you can assume that everything that happens gradually in a person occurs very quickly in such patients, and the patient usually attain the ages 3 or 4 times quickly as compared to normal individual. And among the aging, it is not just the skin aging, but aging of the whole body, which include all the other systemic complications that comes with the aging. Pathophysiology. It's an autosomal recessive disorder caused by mutation in gene RECQL2 or Werner gene, which is seen on chromosome 8. The region is P12 or P11.2. The syndrome appeared to be at a higher frequency in Japan, where the incidence is approximately 3 per million. Clinical features. Patients with Werner syndrome generally have a normal growth and development until puberty, when there is lack of growth spurt and other clinical features start to manifest. The cutaneous features include thin, taut, sclerodermatous skin, particularly on face and extremities with subcutaneous calcification. There may be ulceration around the ankle and elbows. Face has a prematurely aged appearance with beaking of nose, sparse, prematurely gray hairs. Stature is short with slender limbs. Patient develop early atherosclerosis, diabetes, osteoporosis, hypertension, and hypogonadism and are at risk of cataract and retinal degeneration. So all the systemic features of aging is seen in other systems as well. The Werner syndrome patients are predisposed to developing malignancies, particularly the myeloid disorders, meningiomas, melanomas, thyroid cancers, and osteosarcomas. Median lifespan is mid-50s, with death usually result of myocardial infarction or malignancy. Management. The complications of Werner syndrome, such as cardiovascular disease, diabetes, and cataract, are treated conventionally as and when they arise. Recently, in vitro research suggests that abnormal cell phenotype may be amenable to treatment with mitogen-activated protein map kinase inhibitor or rapamycin. Mitogen-activated protein kinase inhibitors or rapamycin. This is again a new development in the treatment of Werner syndrome. The second disease or second syndrome we are going to discuss among the heading of prematurely aging syndrome is the Bloom syndrome. Bloom syndrome is also known as the congenital telangiectatic erythema and stunted growth. This syndrome is determined by autosomal recessive gene that is characterized by telangiectatic facial appearance or erythema, short stature, distinctive faces, and abnormal immune response and predisposition to malignancy. So most of such syndromes have some abnormal immune response and incidence of malignancy. The cultured lymphocytes and fibroblasts show high incidence of chromosomal aberration. The gene of Bloom syndrome, which is RECQL3, lies on chromosome 15, region is Q26.1, and encodes a DNA helicase RECQ protein like 3. Bloom syndrome occurs with greater frequency in Ashkenazi Jews, accounting for approximately 1/3 of all cases. So 1/3 of all cases of Bloom syndrome is seen in Ashkenazi Jews. Clinical features. The first and foremost is the telangiectatic erythema that developed during infancy or early childhood as red macules or plaques, most numerous on butterfly area of the face, but may also involve the margins of eyelids, forehead, ears, and dorsa of hands and forearm. There may be slight scaling, exacerbation after sun exposure, but light may also provoke bleeding, and crusting of the lips. Bully in the erythematous areas and bleeding and crusting from the lips. They have narrow, slender, delicate faces with a relatively prominent nose. Limbs tend to be long and large hands and feet, and there is reduced subcutaneous fat. Birth weight is low. Growth disturbance is proportionate and of moderate degree. Patient is hypogonadic with testicular atrophy, and adult male appears to be infertile. There is T and B cell immunodeficiency. IgA and IgM levels are reduced that predispose to pneumonia, bronchiectasis, and chronic lung disease. There is no impairment of neurological development. However, most patients are underperformers in the school. Bloom syndrome patients have an increased risk of developing type 2 diabetes. Some develop unusual personality features and behavioral patterns secondary to their unusual appearance and small size. The mortality from neoplastic diseases, particularly acute leukemia, during second and third decade is significantly increased. And it is estimated that there is 150 to 300 times increased risk of developing malignancy relative to normal. The management. Early diagnosis is important for awareness of possible malignancies and for photoprotection. Regular screening for diabetes and malignancies is important. That include skin surveillance, colonoscopy, and fecal occult blood testing. Aside from this, standard cancer treatment and treatment of associated disease like diabetes is important. The prenatal testing is successfully undertaken by SCE analysis in chronic villus cell cultures as well as from RECQL3 screening from chronic villus or amniotic cells. Progeroid laminopathies and related conditions. Laminin comprise of a type of intermediate filament which collectively are important structural protein of nuclear lamina beneath the inner nuclear membrane. The lamina mutation, LMNA mutation, results in number of different syndromes termed as laminopathies, with variable phenotypic features depending upon the site and nature of mutation. While some disorders are characterized by progeroid features, others involve cardiomyopathies, muscle dystrophies, peripheral neuropathy, and lipodystrophy. Then the fourth syndrome in the category is the Hutchinson-Gilford progeria syndrome, characterized by growth retardation with premature and accelerated aging from early childhood. Affected individuals usually lie in childhood or teenage years due to cardiovascular causes. The syndrome is an autosomal dominant condition with a birth prevalence estimated as 1 in 4 million. Mutation is seen in gene encoding laminin AC, lamina, or on chromosome 1, region Q22. Histopathology show there is thickening of dermis with normal epidermis, but later epidermis is thinned with reduction in sweat glands and subcutaneous fat. The clinical features: by first year of life, failure to thrive with height and weight below the 3rd percentile. This growth retardation persists and worsens thereafter. Individuals develop typical faces with small reduced mandible, pointed tip nose, and narrow bridge. Scalp veins are prominent, partial or total alopecia, also affecting eyebrows and eyelashes. Eyes tend to be prominent, lips are thin, and earlobes may be absent. There are sclerodermatous changes of trunk, limb, and reduced subcutaneous fat, joint contractures. Nails may be dystrophic. The bone changes include osteolysis of distal phalanges and delayed closure of anterior fontanella. Primary dentition is late to erupt and may not be lost, leading to overcrowding of the teeth. Features of accelerated aging becomes obvious later in childhood that include pigmented, aged appearance in the skin, conductive hearing loss, osteoarthritis, atherosclerosis, leading to cerebrovascular disease, Raynaud's phenomena, and insulin resistance. Individuals do not reach completion of secondary sexual characters and hence do not have children. The classical syndrome is usual survival is around 6 to 20 years and mean survival is 13 years. Death usually results from myocardial infarction or heart failure or stroke. Diagnosis is suspected clinically from a combination of profound growth failures, typical physical appearance, and premature aging. Management is centered around monitoring the disease progress, preventive care where possible, and treatment of complications. Low-dose aspirin is recommended and sun avoidance to limit the cutaneous signs of aging. Recent research have highlighted some potential therapeutic agents like paravastatin, lonafenib, and zoledronate, as well as rapamycin. Mandibuloacral dysplasia with type A and type B lipodystrophy. It's an autosomal recessive growth disorder with growth delay, skeletal abnormalities, lipodystrophy as the name signifies, and pigmentary skin changes. Pathophysiology caused by homozygous or compound heterozygous lamina mutation. Clinical features: there is postnatal growth retardation, progressive osteolysis of clavicle and distal phalanges, mandibular hypoplasia, dental overcrowding, delay closure of cranial sutures with progeroid appearance. Lipodystrophy results in loss of acral fatty tissue. There is impaired insulin resistance and diabetes occur. Cutaneous changes include patchy pigmentation, atrophy of skin, sclerodermatous changes with stiff joint and alopecia. Then cutis laxa, both autosomal dominant and recessive types. The cutis laxa is a group of conditions in which skin lacks the normal elasticity, leading to loose, wrinkly, premature appearance. In addition, there is disorganization or fragmentation of elastic tissue in other organs, notably the lung, cardiovascular system, joints, GI tract, and genitourinary system. Some forms are associated with developmental delay and neuromuscular compromise. Defect in some proteins involved in elastic fiber formation, such as fibrillins, and elastins, resulting in different cutis laxa phenotypes. The autosomal dominant cutis laxa is characterized by autosomal dominant mutation of elastin gene, ELN, lax skin and premature aged appearance, onset between childhood and early adulthood, as well as with gastrointestinal diverticula and inguinal hernias. Elastic fibers in skin are sparse and fragmented. Autosomal recessive cutis laxa characterized by a number of different gene defects. ARCL type 1, autosomal recessive type 1 comprises of severe form with life-threatening complication and death between infancy and young adulthood, usually from cardiorespiratory compromise. In all three types, skin changes are generalized, but may not be particularly prominent over axilla, neck, groins, and give face a droopy aged appearance. Atelectasis and emphysema is present from early childhood. There are multiple diverticula in GI and genitourinary tracts. Less commonly inguinal hernia, joint laxities, hip dislocations, and delayed closure of frontanelles. Facial dysmorphism and postnatal growth delay may be seen, but intellectual development is normal. There are two related syndromes. The De-Barsett syndrome is a form of type 2 autosomal recessive cutis laxa, in which there is generalized cutis laxa, giving a progeroid appearance, pre- and postnatal growth delay, clouding of corneas and cataract, and severe developmental delay. So the main effect is on the eyes. Then occipital horn syndrome is an X-linked recessive disorder characterized by calcification over the occipital bone at the site of muscular insertion, with features of lax skin, inguinal hernia, joint laxity, tortuous blood vessels, and some intellectual impairments. Management. The hip dislocation is checked clinically with ultrasounds. Also look for inguinal hernias and abnormalities of CVS. An echocardiogram, chest computed tomographic scan, MR, angiogram, and pulmonary function test may all be indicated. Similarly, renal ultrasound, Whiting cystourethrogram, barium enema may demonstrate evidence of diverticular disease. A full ophthalmological examination and neurological evaluation with EEG and brain MR scan is indicated. Management for complications as refractive error, emphysema, hip dislocation, inguinal hernia, and seizures. A beta blocker or angiotensin converting enzyme inhibitors may be indicated if dilatation of aortic root is identified. There is an encouraging result with angiotensin II type 1 receptor antagonist, losartan, in Marfan syndrome results in future clinical trials in cutis laxa. Surgical management of aneurysms and other cardiovascular abnormalities. Botulinum toxin injection and plastic surgery is done for facial defects. Thank you all for listening to a relatively longer lecture. So see you next time with some other disorders of genetic defects. Thank you and have a good day.